So the initial graph I showed you was this interim analysis, and that was done because, again, they stopped this because it was so much in favor of the drug. They then did what we call an updated analysis, and what you can see here is the curve split even more. Here, remember I said it was about 4 months, now it's approaching nearly 5 months. So again, the longer you're on this, the more robust the data, the better we're seeing. This is the group of gentlemen with that more advanced ECOG status. You can see that these curves sort of cross here or come together here. There was very, very few patients in this group. And so what we're saying is, yes, we see this. We still feel that the advantages are there across the board. And these are just other ways of looking and showing you what I showed you on those forest plots, where the difference is not in terms of a month or two. The difference is literally 4 to 5 months in terms of survival. And that survival you're getting is excellent quality of life. These gentlemen are apparently going off to California and having a good time. So they tell me anyways. And again, here's just the graph, the separation of, you can see 11 months, 17 months in terms of if you've only had 1 line of chemotherapy versus 2. The final sort of bit of information here about what these drugs can do talk to what we call skeletal-related events. And some of you may have heard this term, but what this refers to is either pain or fracture or some insult to the bone that is important. Do you remember what I said? Literally 80% of individuals who have advanced prostate cancer will have that cancer go to the bones. And while individuals might say, well, it's only my bone, it's not my liver or my lung, it's not important. It is important, because when bones start to break, we have information that says, in fact, death will come a little bit sooner. In other words, that really means a difference. It probably means a difference because when you're laid up in bed, you're more likely to get a pneumonia or more likely to have a complication. It also probably means we can't give you good therapy when you're lying in bed. And so for a combination of these reasons, in the majority of cases, if you have an event that puts you in bed, such as a broken leg bone or something along those lines, this can be a life-saving or other event. So looking at what we call time to these skeletal-related events is important. And do you remember I said there's a drug we use called Zamita that we have been using to try and block these events? Well, even in individuals who weren't on these bone builders, using these therapies alone, we could delay, literally double the time between having a skeletal or a bone event off and on therapy. So these therapies are that potent. They're keeping you alive longer, but they're also giving you an excellent quality of life by preventing these bone problems of breaks and fractures and pain, etc. Now, what about the side effects? They're actually incredibly well tolerated. I mean, you get nothing for nothing, but for the most part, they're exceptionally well managed. As I told you, we have to write down every single thing that these gentlemen have told us. So this is the whole laundry list of what has been reported. In my experience, we have to monitor hypertension. In those individuals that have had hypertension, sometimes we've had to increase the dose, but that's quite manageable. Sometimes there's a little bit of fluid retention, but it's really quite mild. It's not this bad bloating of being on Decadron with that whole puffy face and bloating that you see. We usually will watch, this is meaning low potassium, we usually watch that early on. After a number of months, if there's no problem, we stop fretting about it, we check it just when you come back. And these other side effects, it's unclear to me whether they're truly a one-off. In other words, I'm sure an individual man might have them, but it is not the majority of men I'm seeing. we have to check your liver, we have to check your electrolytes, we fuss about your hypertension for a bit, but for the most part, if you're feeling well, you are doing well. So this is the summary of looking at all those trials. These are the names of them, and this is the drug that we talked about. You can see these are all very, very large trials, and this is the difference in survival. And what you can see in all of them, there's an important survival advantage in favor of these new drugs. And the pickle we're in is trying to get them and then trying to sequence them. And it's a nice pickle. Well, first I want to get them, but once we get them, it'll be a nice pickle to be in. So this is the summary, I stuck it all here because people wanted the slides, so you can go back and have the, actual numbers. But again, you can see the difference is literally about 4 to 5 months in favor of amiodarone in this survival. This is that updated analysis. That benefit was seen in all subgroups of individuals. Didn't matter, had you had chemotherapy, young, old, with pain, without pain, everybody had an advantage, a little bit more, a little bit less, but everybody did. And the toxicity was exceptionally mild. This cabazitaxel is a very, very toxic drug. Interestingly, on top of that, the survival is only 2.5 months. I think the majority it is really a challenge to deliver. We are now running a trial where we're looking at 2 different doses to see if that lower dose will be better tolerated. If it's better tolerated, can we get more of the drug in? If we get more of the drug in, will this number change? This, what we call febrile neutropenia, which is infections, low blood, is really becoming a problem. And this is, as I said, clearly not seen on any of the pills. This drug may not find a home in advanced prostate cancer, or at least in the majority of men, I don't think it's going to find a home. It may be that we get this drug ultimately approved here in Ontario, and it's the odd individual who's an extremely young, fit individual, so it'll be a little bit of cherry picking. We are now lobbying the government for all of these drugs. I will tell you there's no way the government's going to give us all. They will probably word it something like, you can have your choice of one of these drugs in this setting, take your pick. It's a little, and I'm saying that because they did that in breast cancer in a similar environment. There were 2 good drugs that would fit the bill, something like MDV 3100 and amiodarone. They wouldn't give us both. They wouldn't say they wouldn't say one was better than the other. They said, okay, boys and girls, you can have it, you can pick one, and we will fund one. And once we funded one, that's it. So take your choice. It's before the government now. Letters have been sent. There's a huge advocacy campaign ongoing. I've gotten a letter back from my favorite lady, Diane. It's a form letter. We're pushing. Stay tuned. I'm not quite sure what's going to happen with all these government cuts, but I think people they can't ignore us. I'm just not quite sure how quickly they're going to get to us. And so this is sort of my take on what's going to happen. And what we're now doing in the clinic is trying to use insurance policies our best, but it's a little bit of a challenge right now because we can't get drug from the government. We can't yet get free. There was what we call an early access program from the companies. The first one's closed. We hope the second one's going to open soon. I'll let you know in June after the data is released for the second one. But it's a little bit of treading water and figuring out where